This panel is directed to the topic of the ACA, specifically the implementation successes and failures. It's a hot topic and one that has been a hot topic for a while now. We've got two great discussants today, and I'm going to ask them to open with some remarks, and then we'll have a discussion and open it to the audience. To my immediate left is Niyam Yuragi. He is a fellow here at the Brookings Institution Center for Technology Innovation. He's an expert on the economics of healthcare information technology, and he focuses on health information exchange systems. His research examines the network externalities in the healthcare market and their effects on adoption and usage. And he's currently focused on analyzing the outcomes of health information exchanges in reducing the cost and increasing the quality of healthcare. To my far left is Eric Potashnik. He is a professor of public policy and politics and director of the Center for Health Policy at the University of Virginia. He's also a non-resident senior fellow here at Brookings and a fellow of the National Academy of Public Administration. And he's previously held faculty positions at Yale and UCLA. He served also as Dean for Academic Affairs at the Batten School between 2009 and 2012. His latest book is Living Legislation, Durability, Change, and the Politics of American Lawmaking. And he's also the author of Reforms at Risk, What Happens After Major Policy Changes Are Enacted, a book I used to assign to my students at Harvard all the time because it's one of the best books ever written on this topic. So with that, I'd like to call on Eric first because, in fact, Eric recently wrote a Washington Post piece that was quite intriguing, and it began with the question of, do government programs ever die? Which has always been one of my favorite questions, okay, and in fact started many decades ago by a political scientist who wrote a famous piece called Are Government Programs Immortal? And Eric has an interesting take on that, and given that a good almost half or around half of the political establishments in this town is trying desperately to make the Affordable Care Act die, I thought that might be a good place to open up, and then I'll move to Niyam.
Thank
Eric?
you. Well, it's a pleasure to be here. I think the conventional wisdom among many is that when government starts a program, it's impossible to unravel. And yet here we are talking about the durability of the Affordable Care Act and its fate and what will happen. When President Obama signed the ACA into law, both supporters of the act and detractors made bold predictions. And as we take stock of where the ACA is today and its trajectory going forward, I think what's striking to me is how many of those predictions turned out to be wrong. So on the Republican side, Paul Ryan and many other conservatives argued that the law was going to collapse under its own weight, that public outrage over the law, that the inevitable insurance death spirals would lead Congress to repeal the law. They were making this prediction early on that this law will not stand, this will not last. And yet what's striking, I think, to me is that despite Republican congressional victories, damaging Supreme Court decisions, website failures, and so on, the law survived. And advocates can point to key achievements, including big gains in healthcare coverage, improvements in the access to health services, and whether it's due to the ACA or not, historically low growth in healthcare costs. And so that's really, I think, pretty striking that these initial predictions that the law would quickly unravel turned out to be wrong. And yet at the same time, if we look at the predictions that were made on the Democratic side, the optimistic prognostication of supporters that the controversy would die down and that the law would be solidly entrenched as soon as it was passed also, I think, turned out to be wrong. People knew when the ACA was passed that it was, controversial, not overwhelmingly popular. It was an amazing thing just that the law passed. And yet the prediction, I think, of supporters was that, yeah, this is the politics of enactment. But once we get to the implementation stage, once we see that the benefits are flowing, people are going to love this law. Presidential advisor David Axelrod said, as the American people become familiar with what's in this program or what isn't, they're going to be very, very happy with it. Well, here we are 5 years later, and public opinion on the law remains mixed. Opposition among conservatives remains intense, and the law still faces existential threats. Even if the Supreme Court upholds the subsidies flowing to Americans who get their insurance through the exchange, I think the fight over Obamacare is not over. And why is that? Well, in a nutshell, I think we have to realize that the ACA is a very unusual law. It's really hard to point to another example of something just like it. A lot of supporters of the ACA compared it to Medicare. They said, this is going to be like Medicare. But the reality is, this analogy was never a particularly good one. The two laws are really different. Medicare was fully operational after only a year. I mean, the law passed in 1965. By 66, 67, this thing was going very well. Yeah, there were difficulties getting doctors to participate. Initially, there had to be desegregation of southern hospitals. There were important administrative obstacles that had to be overcome, but they were overcome. And here, of course, there's been many more glitches and difficulties rolling out Obamacare. Medicare was also passed with strong congressional majorities. It was somewhat partisan, but there was some Republican buy-in from the start. We didn't have the same kind of razor-thin, acrimonious party line votes to pass something as sweeping as Obamacare. Medicare was built on the popular Social Security model. It was a huge immediate benefit to the elderly. The ACA is very different. In contrast to Medicare, as John Oberlander has pointed out, the ACA is not a social insurance program with a clearly identified constituency that has a clear connection to benefits. It's not really even a single program. It's rather a series of subsidies, taxes, rules, and regulations that treats different people, different groups of Americans differently at different times. Some people are benefiting from the ACA because they're kids and they can stay on the insurance. Some people are protected in other ways, but it's not like everyone sort of says, I'm an ACA beneficiary, the way people think of themselves as a Social Security beneficiary. So this is a very distinctive law. It's unique in the way it was passed, it's unique in the way it was designed, and it's in some ways unique in the way the fight over enactment has continued.
Great, thank you. You know, I would just add to that it's really interesting the way you have looked at this, because one of the things that has struck me about the law is that it actually affects a relatively small number of people in America. The elderly have Medicare. Most people in their prime working lives are covered by employer-provided health insurance. And so we really are talking about 14 to 15% of the population. And one of the things that's always struck me about that 14 or 15% is that they go in and out of the healthcare market. So it's not like it's a permanent, it's not like that 15% are the same people who can always be mobilized. But a lot of these people are people who are in between jobs, then they get a job with healthcare, right? And then they go out and they maybe become an entrepreneur or something, and then the ACA is great for them, and they buy it through an exchange. But it's not a permanent class of people in the way that the elderly at any given time can be mobilized to protect Medicare benefits.
I think that's exactly right. Small constituencies sometimes can be powerful. There aren't that many farmers left in America.
Not many.
Because they're a compact group, they're well organized, they know their interests, they monitor federal legislation. This is a program, as you say, the percentage of the public that directly benefits is not overwhelmingly large. It's not like Social Security, but it's also not well defined. Yeah. People don't know when they're going to become a beneficiary. They're not counting on it in the same way. The reality is there's many, many millions more that are benefiting indirectly through the ACA. The fact that you have a child, that you know that someday when they're an adult might have secure health insurance. The fact that you have a relative that might have a pre-existing condition and you can rest easy at night knowing that they'll be covered. Well, that's a benefit for sure, but people don't see the connection. Right. Political scientists know that what matters in politics is not simply the benefits that flow to people, but how visible they are, how traceable they are, how reliable they seem. In all those ways, the ACA is problematic. And I think what's key to see about the ACA is that the ACA was not designed, actually, to make it as transparent as possible, as easy as for people to buy into it, Rather, the ACA was designed primarily with passage in mind. It was designed to make it feasible to reform the pre-existing employer-based healthcare system, to retain that system, but to bring more people into it. Because of the overwhelming need to adapt to those enactment barriers, the policy itself has not structured in a way that promotes its own sustainability.
Interesting. Neil, what do you have to add to this conversation?
Well, I would like to look at Affordable Care Act law from a completely different perspective and say that it's a law that has different components. And although not all the people may like all of its components, there is one aspect of it that I believe every person loves, and that it's promise for promoting innovation. In the previous panel, we were talking about the reforms in payment models and financing healthcare. And the reason for the fact that we can now claim that we have started to be successful in that area is the fact that we really needed to be innovative in that area. If we could not reform how we finance medicine in this country, we would have major problems in terms of financial. We simply couldn't afford to continue the fee-for-service payment model. So we could successfully come up with a model that different players in the system are agreeing upon it, and we can now say that in 2018, 50% of our medical providers would be a part of this pay-for-value payment models. The other area is that the Affordable Care Act was initially designed to improve where the efficiency of healthcare. So through Obamacare, we are not only intending to provide universal health care for every American in the United States, but also we like to reduce the cost of health care by increasing efficiency and increasing quality. Although we are celebrating the success of Affordable Care Act in many ways right now, but I think we are not able to say that we have also been successful in implementing the policies to make the medical practices more efficient, because we forgot that the critical success for every innovation to succeed is to have a need for that particular innovation. The payment reform succeeded because we needed to reform the payment system, but the other innovations, in particular, the information technology implementation in healthcare, has not been as successful as we planned, because we forgot the critical fact that it may not necessarily be in the best economic interest of many different players in the United States healthcare system to adopt such systems and thus become more efficient.
That's very interesting. Can you give us an example of a sector in the healthcare economy that's resisting innovation, where it's not in their interest?
So, the HITECH Act, enacted in 2009, allocated $35 billion so that HHS can come up with incentives in order to drive medical providers to adopt electronic health record systems, so that they can capture the patient's data in electronic format and then exchange it with other medical providers. I think we all agree that if doctors have access to your medical records, they can make much better decisions, and thus they can, avoid redundant tests and provide care at a higher quality, which all means that they would become more efficient and reduce the costs. We have now spent $28 billion out of those initial $35 million. about 90% of, or more than 90% of the medical providers in the United States have an electronic health record system. But the surprise is none of them can exchange their medical data with each other. So instead of having a copy of your records in paper, now your doctor has it in his computer, but that's it. You know, we spent $28 billion so that instead of writing on a piece of paper, we have it in a computer, and we cannot exchange it with each other. So why this has not been successful, and now this is the debate over the interoperability issue and why these different kinds of electronic medical systems cannot talk with each other, and why can doctors exchange the medical records with each other. Apart from the technical issues, another aspect that we're forgetting is that if you're an owner of a radiology center, if you have invested in a lab center, in medical testing center, the last thing that you want is to let your patients have their records electronically in order to reduce the likelihood of redoing a blood work. The current system of fee-for-service model incentivizes the labs and radiology centers to do as many redundant and repetitive tests as they can, you know. And now you're going and telling them, hey, why don't you put your results electronically on a system so that the doctors can have access to it and avoid reordering it? I mean, that's the last thing that they would like to do. So now we are facing a situation in which all of them are potentially providing it in electronic format, but none of them can exchange it with each other. And the reason is, if they want to exchange it, means that they are intentionally cutting their potential market, and nobody wants to do that, regardless of the type of the business that you're working in. If you have a restaurant, you will never want to reduce the number of potential customers in your restaurant. So if you are a testing center, you will never want to reduce the number of test orders to your facility. So you don't want to be successful in that part. So when we're talking about innovation, we should ask this question: do we need this innovation? Is it going to help us economically or not? In the current system, no, we don't need it. We really want to kill it, and everybody wants to do that. It doesn't matter whether you're a Democrat or a Republican. You know, it is targeting the bread and butter of your business. It depends on your monthly and annual income, your return on investments, and that's a bad innovation. So it's like going to the taxi unions and asking them to help Uber. They would never do that, and the same is happening here.
Same is happening here. This is fascinating. Did you want to add to that, Eric?
I did. So although I think the primary goal of the ACA is to expand access, one of the things that's distinctive about the law is its ambitions to try to improve the delivery of healthcare, not simply to bring people into the system, but to make the system more efficient. And we need to remember that the U.S. spends dramatically more than any other country on healthcare, 18% of GDP around, and yet it's clear that a lot of what we spend money on is not high value. There are many reasons for that. We've already talked about fee-for-service. One of the problems that the ACA is trying to target is the problem of weak evidence supporting the healthcare that actually is delivered by doctors. Mm-hmm. Some studies show that less than half of all the treatments that patients receive is based on an adequate base of evidence. There has been significant work by economists that show we have a lot of regions in the country that spend much more than other parts of the country on healthcare, controlling for the kind of patients they have. They're not producing better results. So that was the promise of the ACA, that there's a lot of waste in the system. If we could identify the waste, perhaps we can make it more efficient, and we could use those savings to expand access. That was the hope for it. The ACA includes a number of reforms that were directed to try to promote more evidence-based healthcare delivery. One of the most important was setting up a new agency called the Patient-Centered Outcomes Research Institute that is a nonprofit entity that is supposed to fund research on what treatments work best for different conditions. And the idea is you have back pain. What's best? Is it surgery? Is it physical therapy? What's best? For lots of common illnesses, we actually don't know the answer to that question. We don't have good evidence on what works best. When the FDA approves a drug, normally it just looks whether the drug works better than a placebo. We often don't know, is drug A better than drug B or better than treatment C? For patients, we need the answer to those questions. Or for your loved ones, you certainly want them to get the best possible care. So from a quality standpoint and from a cost control standpoint, that's important. And so this agency's been around for a couple of years, and the question is it beginning to have any impact? Is it actually making any difference? There was a recent survey done of key stakeholders in the healthcare sector by the National Pharmaceutical Council, and the answer was basically no. Overwhelmingly, I think it was more than 8 in 10 of key stakeholders saying that this effort to promote evidence-based medicine is not yet changing how our healthcare system is working. Everyone is hoping that it will, but it hasn't yet. And there's a couple of reasons for that. The law itself, because of all the controversy over death panels and a concern of rationing, it limits the authority of the agency. So the agency can't mandate Medicare coverage decisions, for example. The information could be taken into account by CMS, but there's nothing requiring it to. The agency was also heavily constrained from performing cost-effectiveness analysis, the way it's done in European systems. We're very, very concerned about anything that interferes with the doctor-patient relationship. A lot of doctors will say they want better evidence. But of course, if you look at how it impacts their own practice, they're very reluctant to change the way they deliver medicine if information suggests that some of the things they're doing might not be as effective. This agency is only authorized for a couple more years. It's not clear that it will be reauthorized. So far, the agency has not had a big impact. I think most Americans, even those who follow it, have not been aware of it. The studies that are being funded are taking a while to have an impact. It's not clear that anyone's going to really feel that this agency is adding value when it comes up. This is no fault of the people who are running the agency. It just is underscoring how difficult it will be to transform the American healthcare system, not only to one that covers more people, but to one that is higher value and more affordable.
So this is kind of analogous to what you just brought up, Liam, that basically there's reforms. They are implicit or explicit in the law. They're intended to bring us in the right direction, but they don't fit the incentive structure of the current system. So you've got doctors resistant because they don't want to be told they interfered with their practice. You've got doctors not using this. The electronic
records.
Systems. I've also been told that the doctors feel that the electronic entering the data interferes with their actual patient relationships, and people are hiring note takers to come in and put it in the computer, et cetera, et cetera. So there's a lot of resistance to getting us to a place where we can have basically better healthcare, better quality.
Well, one thing we haven't talked so much about is the larger context in which these reforms are taking place, and that is a highly politicized context. Mm-hmm. What's really, I think, been striking is that many of these reforms that are intended to promote cost control, quality, these are not Democratic reforms. These are not Republican reforms. They really are bipartisan, technocratic, good government reforms. The agency I was just talking about originally, that whole idea actually predated the Obama administration. The earlier Bush administration was trying to promote evidence-based medicine. One of the key advocates of this agency was Gail Walensky, who had been John McCain's healthcare advisor. Mm-hmm. And yet the problem was some of these quality reforms got wrapped up in the broader debate over Obamacare. And therefore, they became polarizing. And this is one of the problems we're seeing in Washington now, is that even when there's a bipartisan consensus on efficiency, on problem solving, if it gets caught up in these currents, we lose that bipartisan support for it that we need in order to bring about transformational change.
Exactly. Liam, did you want to add to this?
Yeah, I just wanted to confirm, as I said at the beginning, almost every initiative about making healthcare more efficient and reducing the cost of healthcare has not only bipartisan support, but also very strong bipartisan support. Everybody loves it. But when you look at it, unfortunately, the economic incentives are designed in such a way that even with very strong bipartisan support in Washington, you cannot do anything in the actual practices. Mm-hmm.
Yeah, this reminds me of an old piece of political science that talked about street-level bureaucracy. Remember that? So there's the the policymakers are all saying, yes, of course, this is the right thing to do. This is the right thing to do, and then you get down to the street and the actual implementation, and it just doesn't work. It doesn't fit the way people are behaving or the way people think they ought to be behaving.
I think the hopeful news here is, the good news is that these changes in the payment models that are promoting value and quality would have a side effect. And the side effect is that the medical providers will now understand that it's in their best interest to become more efficient. Now, the payment reforms have created that missing need that we required for having successful innovation in other areas. And now that, by 2018, they said 50% of the payments would be in a format of payment for value system rather than payment for fee for service system. We're going to have a completely different landscape in which now it is in the best economic interests of medical providers to become more efficient in order to increase their margin of profit. So we're going to observe so many different changes in each of these medical providers towards becoming more efficient. However, I highly doubt that those changes would be the changes prescribed from Washington. Those changes are the changes that are grown naturally within each medical organization based on the needs and characteristics that are unique to that specific organization. Those changes wouldn't be attesting to meaningful use stage 1 or 2 or 3 criteria. Those would be the actual real changes that information technology may or may not be one of them in order to become more efficient. And as a side effect, patients would benefit.
Gotcha.
Yeah, so I'm picking up on that last point. I think one of the problems with the ACA is that it was designed to make sense technically. But thinking about, as we've been talking about, how do you build a durable coalition to make this stick and to bring about change is really an exercise in political entrepreneurship and political creativity, not simply technical design. And so the agency I was talking about that hasn't made a big impact yet, that's unclear, even though it should have bipartisan support, whether it will even be reauthorized. Well, we can't rerun history, but for example, what might have been another way to try to make that whole effort to make our system more popular, more ingrained into the system? Well, one idea would have been, for example, instead of having an agency in Washington that's a nonprofit entity to sort of give out these research, maybe we should have used a more federated design, right? To try to have, for example, 20 different centers around the country. And so in Virginia it would be for cardiology, and in North Carolina it would be for urology, right? And that those would be the centers of evidence-based medicine excellence. And they would be getting the billions of dollars, the hundreds of millions of dollars, and every time they get the grants, the members of Congress from those districts would say, I'm so proud that my area is supporting this research. We need to think much more in a polarized age of how we can build the new coalitions of support, because we can't count on them naturally arising. It's going to require much more strategic agency building, I think, if we're going to actually transform the healthcare system over time.
Yeah, I mean that is a great point. And I think the other thing people are fearful of is that if the Supreme Court goes against the ACA, then it just peters out. It just peters out without the subsidies, but you'll still be left with some good pieces of it. You'll still be left with the exchanges and the notion of having a place to more efficiently shop for health insurance. You'll still have something, but I think that the Supreme Court could be fatal.
The Supreme Court case is fascinating because it's such a shocking event, and it's also, I think, its effects are unclear. I could see it cutting both ways. On the one hand, it could be exactly what you say. It would be devastating to the exchanges in those states. It may be that this will be the end of it, and that we'll end up with a two-tiered system. There'll be some blue states that will have Obamacare, we'll have red states that won't, and it'll be quite ironic because it'll be subsidies from the red states to the blue states.
Right.
And in many ways, the law was intended to be the reverse. So that's one scenario that in 5 years from now, we're looking at actually the United States does sort of have a healthcare system, but only in some parts of the country, undermining the idea of sort of we're all one country. On the other hand, one can tell a story, I don't know how likely it is, that actually if the Supreme Court rules against these subsidies, it could be exactly what is needed in order to finally entrench Obamacare. Because Republicans and conservatives have been mostly opposing Obamacare in the abstract, right, at the level of ideological principle. Well, now people in those states, in the red states that have the federal exchanges, are getting those subsidies. And these are middle-class people. And some of those states with Republican governors have expanded Medicaid, at least. Mm-hmm. There's going to be tremendous pressure on those states to somehow come up with a way of making it work. And so the real question is going to be, who's going to be blamed? Will Obama be blamed for designing a bad system, or will those Republican states be held accountable if people start losing their coverage? If they are accountable and they have to adapt to the system, that finally, I think, will give Obamacare the kind of bipartisan support it will need going forward.
Because those red states will then start developing their own state exchanges, right, in order to be consistent with the law.
That's right.
I mean, that's very interesting because you're exactly right. This could really go in one of two ways. Before we open it up to the audience, very quickly, I mean, as of this point, what do you see, Niam, as the biggest success and the biggest failure of the ACA today?
I think the biggest success was that they could enroll as many people as we are seeing now, despite the fact that the websites was really cranky at the beginning, but still we're seeing the enrollment number much more than initial expectations. And
biggest failure so far?
As I said, in implementation of information technology in various sectors.
Yeah.
I would say the biggest success is the fact that we've been able to expand insurance without a dramatic increase in healthcare inflation. Whether Obamacare gets credit for healthcare cost control is still a matter of debate, but the fact that costs are under control more than was predicted is tremendous success. The biggest failure in many ways was the surprising Supreme Court decision making essentially the Medicaid expansion optional.
Yeah.
I think in the last panel there was a question about building on Medicare as the way to expand to reach national health care coverage. That was the dream of liberals and progressives for generations, Medicare for all. What's striking about Obamacare was it went another route. It expanded Medicaid. Medicaid had been seen as the welfare program, and Medicaid became the vehicle for national health care insurance for all sorts of reasons. And yet that has been stymied and blocked in ways that no one expected ex ante. And as a result of that, coverage expansion has been less than was anticipated in those states. And we don't yet know if we're at a holding pattern now or if other states finally will begin to come on board.
And my final contribution to this will be that it's given that tomorrow is tax day, okay, what I'm curious about, and it's a little bit, as you were saying, Eric, which about the Supreme Court decision, is how are the tax provisions going to work out? Because one of the things that I have been thinking about is basically this is enforced through the refund system. Okay, the basic enforcement for the ACA is not liens on your property. They're in fact forbidden for doing that, but it's through refunds because, and that makes perfect, that's actually quite ingenious because most of this population, it would make no sense to go, trying to put a lien on their property. But they do, this population saves through refunds. 81% of American tax filers get refunds. So the penalties now will be enacted through the refunds. The question is, as the penalties increase
in the future,
and even this year, and as people get less of a refund than they expected, or in some instances no refund because of this, what will it do? Will it increase opposition to the law? Or, as you were suggesting with in the bigger case, will it in fact incentivize people to finally buy health insurance and get that last whatever percentage through? Now in Massachusetts, these days there's almost no one paying the penalty. Okay, it's down to like 1.7%, 2%. It's very, very small. But that was a state that it's a little different. It didn't have a large number of uninsured, and it didn't have the entrenched political opposition. So I think that there's a lot of things that could go either way in terms of the incentive structures that are built into this. Okay, let's take some questions. Right here. Yes.
First one is easy. You can solve this by waiting. All you have to do is look at the medical students and look at the interns. Every one of them is carrying a portable electronic device, usually given out as a either given out to house officers or as a requirement for medical students to input their information. Nobody goes to libraries anymore. The library is PubMed. It's there, it's available. It's people like me who couldn't type so well, who had to take Mavis Beacon Teachers Typing so I could use email. Yeah. Well, we're slow. So the docs that are out there are going to pass by, and these young people are going to come in completely electronically sophisticated and aware. And all you have to do is look to see them. That's the first point. The second one is with regard to Professor Potashnik's comment about the difference between a Medicaid model and a Medicare model. I couldn't agree more. But I'd go further. If you want to look at where evidence-based medicine took root first, it's in the National Health Service in Great Britain. A national system, like our Medicare system, only better than our Medicare. That can work as long as you have a system based on a federated involvement, based on going from the bottom up rather than the top down. You aren't going to be able to get good, in my judgment, evidence-based medicine promulgated throughout the system. The third point has to do with economic motivation, going back to your bothersome but maybe correct analysis, at least to me. Bundling, outcomes, payments have to be designed for that rather than specific interventions. Your comment about tests and x-rays may be right, but we shouldn't be paying for tests and x-rays. We should be paying for heart care. Mm-hmm. And so, well, you know what bundling is. So I think all three are addressable, but without a national system, we aren't going to get that. The first one I'm not worried about. Kids get older and they keep their computers.
So,
yeah, go ahead. Yeah.
Great points. A few comments. The first one, of course, when these issues of evidence-based medicine and the need to have a more efficient system were discussed during the debate, whenever England was mentioned, and you're quite right, it's NICE, the National Institute of Healthcare Excellence in England, that does this work very seriously. Well, that was anathema. That is, to American ears, that is rationing. That was part of the reason why the agency that was set up in the U.S. was explicitly designed by Congress precisely not to be England. When Don Berwick made some comments about praising England, well, he ran into huge trouble. We have a tremendous belief in the United States that rationing is wrong and that Americans should get all the health care that they want. And we have not wrestled with this culturally and not really come to terms with this. So what's also interesting is that in the U.S. case, the part of the U.S. that's actually in some ways the closest to England in an integrated healthcare system is the VA, actually. And the VA is probably the part of our system that is most evidence-based. For all of their bureaucratic problems, which is so unfortunate, what is the most tragic thing about that is that the VA has done excellent work over the last couple of decades in transforming delivery of healthcare in ways that are more evidence-based. The second point was, I think you're right about this generational change in the young doctors. I see the same thing in evidence-based medicine. When studies find that a particular procedure doesn't work, the surgeons that are doing it, well, they've been doing it, they're used to doing it, they continue, but the young doctors perhaps that are learning it in medical school, well, maybe they're not going to do it. So on the one hand, you could say, see, that's a positive. On the other hand, what kind of industry requires 30 years to incorporate information? I mean, this is even worse than higher education. Yeah. So the transmission of knowledge to better delivery is painstakingly slow in the healthcare system.
Yeah.
Two comments. Regarding the first one, I agree that younger generations are more tech savvy and they are more likely to use technology. But the problem that we have with these EMRs and EHRs is not that we cannot use them. The problem is that even though we are using them, they are useless. So they do not lead to any change because they cannot exchange information. It's like a cell phone that cannot make any calls. It's not my problem as a user that I cannot make calls. I know how to use a cell phone. It's because the provider, AT&T or T-Mobile, whoever it is, that doesn't let me make a phone call. So that is even, 20 years from now, 30 years from now, no matter how young and tech savvy are those young doctors, they would be unable to make any change because how good you are in using your EHR, you wouldn't be able to do anything. And I agree with your comments about, incenting the outcomes rather than the procedures, of course, And that's the main disagreement that I have with high-tech incentives and meaningful use incentive programs. They are incenting procedures. They are looking at how many patients you sent emails to, and then if you have reached a specific percentage of the patients that you sent emails to, then you're qualified for these incentives. It's just like incenting doing radiology images in the healthcare. So,
let's see, Richard here, and then we'll go there and there. Okay.
Hi, I'm Richard Skinner from American University, and my question is particularly, though not exclusively, directed to Eric. If you look at public opinion on the ACA, it is overwhelmingly driven by party and ideology, not by people's personal experiences. I suspect there are people who have had good experiences and still don't like the ACA because they're good Republicans. And I'm sure there are people who have had bad experiences and still support the ACA because they're good Democrats. And you mentioned, for example, the possibility of distributing these centers for evidence-based medicine around the country, but look at the number of Republican governors who refuse to take stimulus money. Look at the number of Republican members of Congress who are basically uninterested in traditional distributive politics because they don't like it ideologically. So my question, and I know you've done a lot of work about how opposition to Social Security actually continued a lot longer than we remember. Why are people seeing the ACA in such strongly ideological terms when I don't think that was the same case with Medicare, but it did turn out to be that way for Social Security until it was expanded to cover more upscale workers in 1950?
So these are great questions. I think one thing that people don't like to discuss about the ACA is it is an extremely redistributive law. It is our most redistributive social law in generations. Social Security was a universal program where everyone is participating. The early generations of Social Security participants got everybody way back more than they paid in. So self-interest was very, very strong. In the ACA, this is part of why the subsidy issue with the Supreme Court is so important. The ACA is giving resources at a time of rising inequality to people that are middle class, lower middle class, and poorer folks. It is not built on the universal Social Security and Medicare model. And so even though we think of the law as in some ways incremental because it's not national health insurance, in terms of the financing, the benefit flows, who wins and who loses, this law is not a law in terms of the way its benefit structure that a lot of Republicans would have designed. In many ways, the ACA really was addressed to two different problems. One was that the insurance market was not working well, right? There were people who had pre-existing conditions, there were market failures, there's adverse selection problems. And economists and everyone agreed that the market wasn't working and we needed some kind of system. And there, perhaps, you could have gotten some kind of bipartisan support. But the ACA went further. The ACA did not simply address the market failures. The ACA was also trying to remedy some broader social justice issues. And it combined, in other words, a solution to the insurance failures as well as these distributional concerns. And it did it in a way that added an element of coercion with the individual mandate that sort of provoked ideological concerns at a time when the country was coming out of the Great Recession and many people did not believe this was the highest priority. And of course, the context is so different. So all of those factors actually make Obamacare very different than Social Security. But the questioner, I think, raises also another good point that is also missed. And that is Social Security itself was not like Medicare. Medicare was popular pretty quickly after it was passed because it had built on the Social Security model. But Social Security was touch and go for a long time. It was passed in 1935. It had to be amended in 1939 because the original financing structure was not popular. And then it really did not become fully bipartisan until the 50s. What made Social Security finally popular was that a Republican president, Eisenhower, said, we, the Republican Party, are no longer going to fight the New Deal. We're going to accept this. And the program, of course, expanded dramatically and then built such a large constituency. What Obamacare will need in some ways in order to finally be entrenched is for the Republican Party to say, we are no longer fighting that. That's not going to happen in the next presidential election, and the question is whether it will happen the one after that.
Yeah, you know, this conversation brings up one of my favorite Franklin Roosevelt quotes in designing Social Security. He did this on the insurance model, not on the pension European model, because he said, no damn politician will ever be able to take it away. Yeah. But it still took a good 15, 20 years, because you're right, Eisenhower was the transitional president to the modern Republicans, because the Republicans before Eisenhower, they fought it tooth and nail.
Outlanded others, sure.
Yeah, they all fought it tooth and nail. Let's see, there was a woman right here, yes. And then we'll go to you.
Sure. Again, Christine here, just to sort of go back to our comment earlier about innovation and the need to change the business cycle. The comment was made about how slow we are in sort of adoption. I guess a question for either one of the panelists here is, what kind of drivers or levers of change do we have? In my view, as a clinician, I'm thinking of, the model of continuing education. I mean, that's something that's out there that, pins to the clinician from an accreditation licensing perspective. There's other ways to sort of bump or improve innovation that can get things over these hurdles. Just some thoughts.
Yeah. I think in this day and age, honestly, we don't need to have to force doctors to attend a class in order to let them know about this new medical innovation. They already have access to the most recent medical findings. Of course, some of the journals will still require a fee in order to provide access to those latest publications, but I think both NIH and other large medical grantors are going toward the way in order to make it public access. So with the as was mentioned, every doctor now has access to internet, to tablets, to computers, to anything. So if they want, they can have the best and most important innovations out there. They can have access to that. The reason that they don't adopt it is that, as I said, they don't need to adopt it. Every change is hard, no matter who you are or where you're doing it. In order to adopt a change, you have to overcome some initial backlash. But the point is, as I said at the beginning, the reason that these different innovations have not been successfully adopted by different parts of the medical system is that they don't need to. If there is a doctor that doesn't like to change the way he treats a specific kind of medical condition, and he argues that I've been doing it for the last 40 years and I would like to continue to do it the way that I started doing it, and he can't get away with it, is because he's going to be paid for what he is doing. If there is a system that says that, look, if you want to treat your patient like that, and have a risk of readmission of that patient of 20%, but there is another model that reduces the risk of readmission from 20% to 10%. And if the patient was readmitted, then you have to redo what you did. If you're not going to pay you, then that doctor, I would guarantee that would say, okay, I've been doing it for 40 years. Let me see what others are saying, if there is any way that I can make my business a little bit more efficient. So to answer your question, not the only, but the best medium of change in the medical system, I believe, is the changes in the payment models.
So I certainly agree that payment is crucial, economic incentives is crucial, but I would add one other point that I think is also important, and that is leadership is going to matter too. We've been doing some public opinion surveys over the last several years to look at what the American public thinks about some of these healthcare changes on the evidence-based medicine side. And what we see, there's a lot of concern about it. There's a lot of fear, a lot of anxiety. But what pushes the public to support, what makes people much more comfortable, is physician leadership. If we sort of tell people, doctors believe these changes are important, we see transformation in people's willingness to embrace these shifts. Physicians really are going to be key. We still have a healthcare system. It was the way the Medicare system was designed. Even though physicians in many ways, it's not the Marcus Welby era anymore, they remain the most important actor in the American healthcare system. We delegate professional authority to them. They are the leaders of our system. In the progressive era, the turn of the century, there was a kind of debate in American medicine about the need for reform, and there was leadership that was emerging to try to make healthcare more efficient, more quality-based. We're seeing some of that now in the healthcare system, people like Atul Gawande and others, but it's still a debate in the medical system about what should the norms of the healthcare system be. What is the responsibility for doctors to be stewards of healthcare resources, to control costs? We did recently some surveys of physicians, and what we see is physicians themselves, in their view of what is the responsibility of their own medical societies, we don't see them fully embracing these ideas. So, for example, we ask them questions of, well, what happens if a medical study suggests that, a treatment doesn't work so well? Should the medical society be educating its fellow doctors, or should it be fighting that study and trying to, maintain Medicare reimbursement? Do you see your society as kind of an advocate, a lobbyist? And a lot of doctors sort of say, yeah, that's what I want my medical society to do. And so we don't, and we certainly don't see any wide embrace of, well, our medical society should be making sure that all of us are really practicing best, the best way and conserving resources. We haven't seen that cultural shift. So we're at a time when I think American medicine is at a hinge point, like we were at the progressive era, and trying to decide, well, what is the responsibility of a doctor? They know the responsibility to the individual patient, but what is the responsibility to the broader system?
It's interesting to me, doctors, when I talk to doctors these days, they sound to me like federal bureaucrats.
They feel beleaguered.
They feel beleaguered, yes. They feel put upon and beleaguered, and the system is doing this to me. And it's a real sort of resentment that they feel like they've been just beat up.
Yep.
Yes.
Just
right
one
here.
comment before the question. Sorry about that. The unique characteristics of doctors is that others have usually very high levels of trust to their doctors for good reasons. You always trust your primary care doctor. Whatever he says, you're going to do that. But the interesting point is that doctors almost do not trust anybody unless it's a doctor. So it's the truth. The very first, the very first, this social networks analysis started from the social networks of doctors to see how they adopt medical innovations. So they asked doctors, what would drive you to adopt this medical innovation? Is it being published in JAMA or NEJM, or is it being advertised on TV? Is it through pharma reps, or is it through the recommendation of your peers? That is the strongest driver of adopting innovation. Mm-hmm. If some other doctor tells the other doctor, hey, I used it on my patient, it was good. And what we are missing here is that, as was mentioned, all of these innovations are forced to doctors from Washington, whom rarely, in Congress we have a lot of physicians, but so they feel that it's coming from somebody who doesn't understand medicine. So I completely agree with the notion of leadership from medical professionals. If it's a primary care doctor like Atul saying that, hey, these EHRs are a good thing. Let's use them. I guarantee that, you know, the adoption rate among doctors for that specific EHR system would be much more for other types of medical innovations, whether it be in prescriptions or other surgery methods or anything. If it's advertised through word of mouth of doctors, then it's going to have a much higher success rate.
Yes, right over here.
I'm Dr. Caroline Poplin, a beleaguered primary care physician. This business of paying for outcomes, let me make it concrete. You have a woman with metastatic breast cancer. She has failed first-line and second-line treatments. There is a third-line treatment with a median survival improvement of 6 months and a price tag of $100,000. And there is evidence supporting that. It's been done by the pharmaceutical company, and it's been published in the New England Journal. You are asking us to ration. What would you do in that situation?
I think you underscore what makes the need to reform the healthcare system so urgent is we are now beginning to have come online new innovative products that have two features. They actually work really well, and they're really expensive. If we're going to have the headroom in order to allow the healthcare system to have those kinds of procedures, we're going to have to get rid of the stuff that we're paying a lot for and doesn't do very much, right? We're going to have to figure out where is the low-hanging fruit, where is the waste, where is there something that costs more and isn't any better than something else, or something that's unnecessary. Because those kinds of products, we have to figure out a way to make affordable. Yeah. It's difficult, I know, and this is when this was proposed, this already created a backlash. And there was one study that suggested it had no impact, and I'm not sure about that because some of the broader benefits of the relationship with the doctor, at least as a hypothesis that maybe they're there. But you're right, that's exactly the kind of issue that we're going to have to be confronting. How do we have the room for some breakthrough drugs that are expensive, hepatitis C, other kinds of areas, unless we eliminate things that are clearly not working very well? Yeah.
Right, last question right back here, yes.
Hi, Julie Cantor-Weinberg, Business and Health Policy Solutions. A comment and then a question. I think one of the challenge over the last several years in healthcare policy making, and your comments reflect this to a certain degree, is that there's assumption that doctors are monolithic. So a primary care physician at the Cleveland Clinic is the same as a rural pathologist. So I wondered, A, if you could address that, and B, the Senate is supposed to vote on the SGR package today, which builds on some of the things in a bipartisan manner that were in ACA. What are your predictions for the ability to change anything else in ACA?
So just, I think my comment to your question also is a comment to the previous question. In the SGR bill, one of the most important change in the SGR bill is that it's proposing the merit-based incentive payments and also affordable care organizations. And for those MIPS payments, they are saying that, okay, as long as you are above a threshold of quality, you're going to have this kind of reimbursement. And as long as you're below that threshold of quality, you're going to have some penalty. But interestingly, they do not talk how to measure quality. They do not talk about how to identify quality. So it's a very big question. So and because of that reason, I honestly don't know about what's going to happen in terms of success for this SGR bill. Obviously, doctors love it for good reasons because it's gets rid of these doc fixes every year and gives them a good raise. But and also it has some tries to solve the problem of interoperability in electronic health record system by introducing economic incentives for people to become interoperable and actively engage in exchanging medical information. So with that regards, I would say I am highly hopeful that we're going to see big changes and big improvements in terms of health IT as a result of passing SGR bill. In other areas, I honestly don't know.
Great. Listen, it's time for us to move on, and I think, Daryl, we're going to move on seamlessly to the next panel. Thank you to Eric. Thank you for Liam. Thank you for the great questions from the audience.